Welcome everyone to this GI mentoring
Oh,
session, and we're very excited for this new course, and I hope that you've begun to study that material, and we'll put the link, of course, for others who may watch this later in the comments in the description. But we are very excited that we have two interesting cases for discussion, and Yun Xiao, I'll turn the time over to you.
thank you so much for this opportunity. Thank you, Dr. Razano, for your two interesting cases for me. And today, our topic is gastritis. I have two interesting cases for everyone. And hold on. Yeah. So before we get to the cases, I want to talk a little bit about the anatomy of the stomach because this is very important for the topic we are talking today. So we know I believe we all know stomach very well, but historically maybe not so much. So uh, from the beginning, it is cardia here, and then we got fundus, body, and antrum, and the pylorus. So different region of stomach have different histology. I will talk it later. And because the stomach has its function, so it has ragi and gastric fold and to allow the expansion of the stomach when filling. And so it's a digestive organ. So it will get lots of stimulation from the outside food or some acid or alkali or something like that. And so um, uh, it has it has mucosa on the surface of the mucosa. It is covered by the mucinous epithelia here, and on the surface is the mucin, usually very thin, and underlying the mucinous epithelia, we have the oxyntic glands here. And from this picture, we can see on the top, this is the mucinous epithelia here. And we got here we call it pit or alveolar. So we got the pit on at the pit, we got the neck mucinous cells here. And depend on the mucosa location, we got the underlying mucinous gland or the oxytic glands. And uh, in the mucosa, we can see between the glands we have the lamina propria, which is in which we have the um, small vessels, lymphatic vessels, and we got the stroma cells and lymphocytes, mast cells, eosinophils, or other inflammation cells. And here is more detail about the cells. So this on the right is the PS staining. So we got the mucinous cells, PAS, stained as bright red. Then on the eight, this is the parietal cells, is large and pink, and just above the muscular mucosa, we got the chief cells. Is a little bit smaller, but it's bluish, and because it secrete the enzyme for the digestion. And on the left, we can see the atrium. We can see the atrium of pylorus mucosa. It usually does not usually does not have the oxytic glands, and usually it is composed mostly the mucinous glands. And from here, these areas we can see the pale ovate cells, like here. This is the neuroendocrine cells. And from this, we can see different part of the stomach. The gland morphology is different. And on the top left, we have the cardia part of the mucosa. On the surface, we have the mucinous gland, and on here also mucinous gland, but we can still see some mixed with some oxyntic glands because it's close to the body part. And on the top right, we can see the body of fundus gland. Usually it has the 1/3 of the depth of the whole mucosa as mucinous glands, and underneath it is the oxyntic glands, like here. And on the right lower is the pylorus or atrial gland. It has, you know, uh, around 1/2 of the gland is the mucinous gland, and on the lower part still mucinous glands, and we usually don't see the oxytic glands like what we can find in the body. So yeah, and here is a comparison between the cardiac atrium pylorus mucosa and the fundus body mucosa. So it depends on its role. So for this part, it secrete mucus and regulation, and the fundus and the body part, it produce acid and some digestive enzymes. And so for the fundus and the body, it will have periental cells like here, and the T cell usually on just on the basal part of the mucosa. And for the D cell is very rare. D cell usually located at the atrium part of the mucosa. And usually, for this part, for the fundus body part, the mucosa is thinner, and it is the autoimmune target of the target, and H. pylori usually at early stage it doesn't affect the fundus or body parts, and so for the pylorus and the atrium parts, there usually no periental cells, no tube cells, but we can see the G cells because it will secrete some gastrin to regulate the function of the stomach, and the mucosa thickness is thinner, and it is not the autoimmune target, and so it's the H. pylori prereference. And here we can get a close look of the mucosa. From here, we can see the periental cells. It is pink, granular-like cytoplasm. And here we can see the T cells here. And the middle picture, we got it from the pyloric area. We can see the mucinous gland here. And on the right, we can see the transitional zone mucosa. And we can see most of the gland are mucinous gland. And here is the pyloric type of gland, and we can still see some parietal cells here. And for the normal gland, sometimes we can see rare, occasionally lymphocytes infiltrated in the gland epithelium or in the stroma. And occasionally we can see some lymphoid follicular here, but we cannot see the germinal center usually. So this is in the normal range of the mucosa. And on the right, we can see some, increased lymphocyte, increased inflammation cells here, and we can see some neutrophils here and between the gland. This is out of the normal range of the mucosa. This is active gastritis. Here is on the left the picture taken from the pylorus. We can see most of the gland are pylorus mucinous gland, but in the middle we can see the gland with a lot of goblet cells. This is totally normal because pylorus is close to the duodenal mucosa, so this is the normal with a normal range. And on the right, we see the fundus biopsy. This fundus biopsy, we still know fundus and the body. Normally, the histology should have lots of oxyntic gland, but here we can barely see that. And most of the gland are composed of the branching pseudopyloric gland, like here and here, and we can see some intestine gland metaplasia here. This is atrophic gastritis. So here is, we see the some pale and ovid, crine cells here. When we do the immunohistochemistry for CD6, we can see this highlight these cells. This is the endocrine cells. We call it ECL cells. Here is the musculus mucosa here, just beneath the mucosa gland, and underneath is the fibroadipose tissue, and between that, sometimes we can see the ganglia cells and nerve fibers. It is called Meissner plexus. And here the picture get from the smooth muscle, the muscular prior, and between we can see the smooth muscle here and here. Between it, we can see ganglia cells and nerve fibers. So it is also, it is called Auerbach plexus, and so in the middle of the picture, we can see the CD117 highlights the caudal cells. This is a very important cells that regulate the motility of the stomach. Sometimes, we go to the gist coming from this kind of cells. And on the right, we see the serosa here, and under the serosa is composed of the mesothelium cells, and underneath it is the collagen band and some stroma underneath it. So we are going to get started for our case one. Case one just is a very, this is, we got it from the gastric mucosa, and this is a lower power. So from this view, we can see this is the superficial mucinous gland here, and underneath it we can see some pink area here, and we can see a superficial band of inflammation cell here is very diffuse, superficial. And on high power, we can see the inflammation cells infiltrated between the glands, and beneath the superficial gland, there are the occipital um, glands here. So, and on high power, we can see some neutrophils, some lymphocytes, and some uh, various our inflammation cells. And I guess maybe somebody already know, guess what's the diagnosis? Oh, so from here, we in the gland, we can see something inside. So it's not very clear the picture. So it's digital. So it's yeah. I will show you a clearer picture later. So we did the immunohistochemistry for H. pylori. We can see some positive signal here, and here we can see the rows here. And our final diagnosis is Helicobacter pylori gastritis. So it is very common. It is very common in the so in the population, especially in the developing countries. It is defined out of infection by the gram-negative curved rods. So it affects 50% of the world population. So in the developing country, about 70% of population get infected, and in the Western countries, it only 40%. But most of the people are asymptomatic. 80% are symptomatic. So only some of them get anemia, dyspepsia, nausea, or vomiting, and usually it is actual predominant, and it will because it will get gastrin, increased secretion and acid production, and sometimes it will get duodental ulceration. So here is, the microscopic character, and we can see the superficial diffuse band like monocytic inflammation. Sometimes we can see the large lymphoid follicles. It has a germinal center here, and sometimes we can see the neutrophil in the laminar propria, and sometimes we can see it. It is in the pits. It has a pititis. Here we can see the neutrophil here, just between the epithelial cells. And on the high part, we can do some immunohistochemistry, or we can do special staining to get a better look at the bacteria. So this is immunohistochemistry. This is Wilson study staining. We can see very clearly the small rod-like bacteria here. So on the right, we can see the microerosion here. So here is a relatively normal cells, but here we can get, the cytoplasm, it get disrupted here. Okay, here, sometimes we go to the lymphocyte infiltration between the glands. When it is ill-defined, we have to differentiate from the lymphoma, myeloma. So we did here is the CD3. It highlights this is reactive, and for the H. pylori gastritis, it has most so the natural history for this, it will get the ulcer disease in 5 to 10% of the cases, and 1 to 5% will percent of people will get gastric cancer, and some of them will get myeloma. So because the the chronic inflammation, the for most for the prognosis, if we get antibiotics treatment, the most of the patient will get yeah, they get healed. And we have the differential diagnosis here. The top differential is H. Hamani. So, and the second one is autoimmune gastritis, and the third one is non-specific chronic gastritis. So, this is the high power of the Hamani. So this is also a gram-negative rod. It's usually bigger than the H. pylori. It is 5 to 9 micrometer, and it is a thylakoid corkscrew appearance. We can see it is here. It's very clear. It's very big. It usually freely located in the lumen of the gland. And this kind of bug usually get from the domestic pets, just like dog and cats or cattle. It has a incidence of around 1%, and so it usually has a mild symptom. On the endoscopy, it is very patchy, mild erythema, and on the microscopic, it usually mild chronic active gastritis confined to the atrium. So rarely it can develop to severe gastritis. So the second diagnosis is, I'm talking about is non-specific chronic gastritis. So it's the it is a diagnosis of exclusion. So so we need to exclude the infection and autoimmune disease and the reactive pattern or granulomas or atrophy. So the common causes for this includes prior treated H. pylori, mild microenvironmental irritation, NSAIDs, smoking alcohol, or mild immune response. So we are getting to the case number 2. So it's a 69-year-old woman. So this is a partial gastrectomy from the founders, and we did H. pylori staining, which is negative. So this is the digital picture from the this from the left side we can see the mucosa here, right? And it is like bluish. We can see the superficial gland here, and between that we can see some lymph the tissue gathers here, and so on the right side we can see the branching pyloric gland here, and we can see some goblet cells, and here we can see some pinkish stained cells. That's the we can see some like the intestine metaplasia, and between the glands there are lots of inflammation cells, and we can see the branching gland here and here. And because the specimen is taken from the founders, so the normal morphology we just talking about. So we should be able to see a lot of oxyntic gland, but we can barely see here. So something wrong about this specimen. On high power, so we can see better on the gland. We can see the mucinous gland here, here, and here. This is the pyloric type of gland. And here we got the goblet cells and the pink cytoplasm cells here. And this is the metaplasia, the intestinal metaplasia. And in the laminal propria, we can see the inflammation cells. So on the high power, we can see the inflammation cell is not very clear. So I will give you more clear cell picture. So what do you think is the diagnosis for this case? Okay, so we did some immunohistochemistry for this patient. This is synopsin grania, and we can see some positive cells here, just like linear arrangement, and some like a small cluster here. So it is increased in the number for this kind of the cells. So I guess maybe you already have the diagnosis. Okay, so the final diagnosis is autoimmune gastritis. So it also known as autoimmune chronic atrophic gastritis. It's immune mediated destruction of oxyntic mucosa. Usually it involve the body and founders, usually spares the atrium, especially at the early stage. So if we do the antibody test for the serum, it will get the anti-parental and anti-intrinsic factor antibody. So on endoscopy, we can see atrophic body founders with loss of mucosa folds, and sometimes it will have some polyps. So clinical issue is the patient cannot secrete hydrogen chlorohydrogen. So and it usually has hydrogastrinemia and ECL cell proliferation, and sometimes it has iron deficiency anemia and pernicious anemia. So we can do some ancillary test to detect the antibodies and the gastrin concentration of the serum pepsinogen and the vitamin B12 level to help us to do the diagnosis. So it usually has 3 stages. Stage 1 is early stage inflammatory phase. The stage 2 is the florid phase. It is established atrophic phase, and stage 3 is the end stage. End stage is late burned out stage. So for the early stage, usually we can see the diffuse or multifocal dense basal predominant lymphoplasmacytic inflammation. It has CD four T cells, eosinophils. We can see here and here. And so we can see some mast cells, we can see the plasma cells. And we can see the pseudo pyloric metaplasia here. And here we can still see some parietal cells here. And we can see some metaphil. This is the pancreatic metaplasia here. And here, the second stage is the florid phase. Usually it has marked atrophy or disappearance of the oxyntic glands. So we cannot see the oxyntic gland here. And from here we can see the pseudopyloric gland here, and with some intestine metaplasia, and we can see the neck mucosa hyperplasia, and we can see the inflammation cells infiltrating between the glands, and here is the metaplasia. Here is the end stage of the autoimmune gastritis. We can see loss of mucinous gland here, and here is the intestine metaplasia here. And we can see from the arrow, this is the ECL cell hyperplasia. So it usually is pretty obvious in the end stage. And yeah, we can see here the ECL cell cluster here, and here is a high power of this. And from here we can see the goblet cell and the Pannis cell here. This is the intestine metaplasia. And this is the CD56 staining highlights the linear hyperplasia of the ECL cells and the cluster hyperplasia of the ECL cells. So here is a close look of the hyperplasia of the ECL cells. We can see the pale cytoplasm polygonal cells here. We can see a lot of them, and immunohistochemistry highlights the cells linear hyperplasia and cluster-like hyperplasia. And so here is a table about how to distinguish between the stages. Usually at the beginning of the stage 1, it will have a lot of inflammation cells, and it is getting less on the later stage. And parietal cells, usually on the stage 1, it still easily seen. And for the stage 2, we get it more decreased, and stage 3, usually it is absent. And the atrophy usually on the stage 1 is not so obvious, and stage 2 and stage 3 usually getting severe. And intestinal metaplasia usually on the stage 1 maybe not very obvious, but on the stage 3 usually extensive. And for the ECL hyperplasia, usually on the stage 3 it is very prominent. So we can do some lab tests for this one, and the prognosis usually it can get polyps in 20 to 40% of the cases. Most of the polyps are sessile, usually small, less than 2 centimeters. It can be multiple, and it can also have a plastic polyp, and sometimes the pyloric gland adenoma may develop. So because it usually accompanied the ECL hyperplasia, so it has a more chance to get neuroendocrine tumors. So it has a totally incidence of 5% between 2 to 4 years. So it can has low-grade epithelial dysplasia. It has an annual incidence rate of 0.6%. And it it is debatable for the increased risk of gastric adenocarcinoma. So here is the, we can, I already showed this picture. So it usually has the ECL, endocrine cell hyperplasia. So on some cases, we can get the sheath-like neuroendocrine cell hyperplasia. If the neuroendocrine growth, the size is greater than 0.5, we call it neuroendocrine tumors. So here on the right is tumor is getting big, and we can see the it's the cell size is relatively the same, and we can get the chromatin is hyperplasia, and the still on this power on is this power we can notice see clearly the chromatin morphology, but it's like very very fine, and so on high power maybe we can see some pepper and salt morphology, but this is a well differentiated neuroendocrine tumor. So the differential diagnosis include H. pylori associated atrophic gastritis, reactive or chemical gastropathy, drug-induced gastritis, and Crohn's disease in gastric involvement, and lymphocytic gastritis and gastric motoma lymphoma. So for the first, we go to the reactive chemical gastropathy. So it usually has the foveal hyperplasia. We can see here. We can see the hyperplasia of the foveal gland, and we can see the small muscle fibers extending upwards, and the edemas laminal propria. And usually the inflammation is mild, so it's not like the autoimmune gastritis. The second differential is drug-induced gastritis. So usually this is more acute injury. It will have a apoptosis and a mixed inflammation pattern. So for this, the diagnosis is usually the clinical history is very critical. We need to get the patient the treatment, the clinical history of the patient before we can do the diagnosis. So the third the differential diagnosis is Crohn's disease. Sometimes it can get the stomach involvement. So from here we can see the inflammation cells between the glands, and so we can see the oxyntic glands here. Between that, we can see something like granulomas inflammation. We can see here the histiocyte, like the granulomas nodule here and here. And so from here we can see it is not the autoimmune gastritis. So the other differential diagnosis is lymphocytic gastritis. So it usually has the very obvious lymphocyte infiltrating in the gland and also between the gland. So it often associated with the celiac disease. So from the high power, we can see the lymphocyte infiltrating between the epithelia. It is called intraepithelial lymphocyte infiltrate. And here we can see the lymphocyte, like, the cytoplasm is very rare, just very clear, and um, the chromatin is very dense and very hypochromatic, but it's very, very small cells. It's a lymphocyte. So the other differential diagnosis is gastric mold lymphoma. So from this, the lower power we can see here is relatively, we have less lymphocyte infiltration between the gland, but here we can see the lymphocyte infiltration is more intense, and on high power we can see the lymphocyte is, pretty uh, same in size, is more notorious. And we can see the lymphocyte infiltrating between the epithelia. So for the diagnosis, we need to do the CD20. So if diffuse positive, we should consider this. And it also loss of the gland architecture from here. So the tumor cell infiltrating and destroy the gland here. So here is a comparison table about the autoimmune and the H. pylori gastritis. So it has different features, like, autoimmune gastritis usually infect the body and fundus, and neutrophil usually we can really see it, and the atrophy usually affects the oxyntic gland, and it usually has a ECL hyperplasia is a very important features for the autoimmune gastritis, and it will not have the H. pylori infection, and clinically it will have the B12 deficiency. And for the H. pylori gastritis, we usually have the atrium predominant, and neutrophil infiltration usually very common. And for the late stage, it will develop atrophy, and ECL hyperplasia usually not seen. And we can see, the most characteristic feature is H. pylori staining. We can see the H. pylori rows in the gland or in the superficial gland. And B12 deficiency is very rare. So here is the reference. And so thank you for your participation.
Excellent, excellent presentation.
Thank you so much. Is there any suggestion or questions about this topic?
I saw some questions in the chat.
Okay, let's see.
Origin of the iron deficiency, is it blood loss or malabsorption? So I can talk about that a little bit.
Okay, thank you so much.
It's usually a chronic malabsorption because you need acid to process food, and if you're not making acid, right, you're not going to be able to convert iron into the proper form for absorption. So this patient probably has severe malabsorption issues. Let's see. do we need to suggest the stage of disease with autoimmune? I don't know what Dr. Housel usually does, but I do not. And in my comment is always to correlate clinically because it's also a clinical diagnosis with the antibodies and the B12 levels. And a lot of times the clinicians have not thought of this disease. Uh, you don't see the notes suggesting it or the antibodies having been tested. So we're often the forefront of this diagnosis. So we correlate clinically and let them tie it up. Let's see. Do you usually use IHC to confirm the diagnosis? H.
Let me just
pylori.
comment further on that.
Oh yeah.
I don't ever comment on the stage. I mean, I may say something's really florid or advanced or something, but that's why I asked the question was, do you do this?
You
Because
asked
I
it.
was going to go, maybe I'm going to learn something here. But
Oh,
I
okay.
agree. I
Yeah.
think it's very often unsuspected and comes out of the blue that, oh my word, they should have thought of that sort of thing. And so you really are oftentimes leading the edge of the workup and the evaluation on patients with this atrophic gastritis. And I think that the challenge sometimes is as you've illustrated, sorting out when you may have had other treatments. You know, they may have thought the patient had Helicobacter or something and they've given it treatment. And then that differential between a partially treated Helicobacter versus atrophic chronic gastritis can be quite challenging. So I think that's where the enterochromaffin stains come in to be useful. I wouldn't routinely do them, but I can see the value in that setting.
For the routine IHC, I would say the majority of my florid H. pylori cases, I do not order H. pylori stain, but some people do it routinely. It's kind of how good your H&E stain is and how clear it is. Let's see, another question. Intestinal metaplasia considered a form of atrophy? Yes.
So what about the situation where you just have, patchy intestinal metaplasia, a couple of foci, and you don't see any great degree of atrophic changes. Maybe you still have intact oxyntic mucosa. Is that the
Right.
situation where you'd recommend the antibody testing and things like that to sort of further define it?
Yeah, yeah. I mean, I think sorry about the noise. I'm actually out of my office. So, but I think each institution has like kind of their own thresholds for ordering stains, or each pathologist has their own thresholds for ordering stains. Mine are pretty low. So if I have any suspicion for H. pylori, I ordered stain in that setting or chromogranin just to make sure, uh, gastrin to confirm that I'm dealing with the antral mucosa and it's, not tricking me in these early stages. Those are their harder diagnoses that are easier to miss. So I order stains in those situations.
Yeah, I think that's right. I think the stains for Helicobacter pylori are very institution specific. Although in the United States, I think sometimes they're very economically driven more than clinically driven. Because I think, if you don't have an inflammatory pattern, unless there's something very unusual in that patient, you're not going to find a rare Helicobacter with a stain that you can't suspect, based on the histologic appearance of that superficial band-like inflammatory infiltrative gastritis in the antrum and so forth. So I get a little bit miffed sometimes when I see people who I think are maybe abusing the economy of the situation by ordering the stains on every gastric biopsy rather than using their eyes first and then doing the workup that seems indicated. So another question here, how often does Crohn's disease involve the stomach? I don't know about Dana, but I would say I could count on one hand or the number of gastric biopsies that I've seen that I would say were strongly supportive of Crohn's disease. There have been a number of situations where you may suggest the possibility, but I've never made that diagnosis on a stomach biopsy, and only, one or two times would I say it probably was the diagnosis.
Yeah, I wonder if it would be more prevalent to find in a pediatric population. I'm not sure about that, but I know that that kind of goes with esophageal inflammation, lymphocytic inflammation. You might think of Crohn's disease if you have a very florid case in a child. And maybe that goes along with the stomach, but I don't see a ton of pediatric, and I haven't in my career. And so I've never made that diagnosis on the stomach.
Yeah, you're right. Probably in a pediatric setting, a little bit more common. So Tiana asks, is autoimmune or in autoimmune gastritis associated with a polyp? Does that mean that we should go back to look at the polyp to consider autoimmune gastritis, or is the polyp secrete the antibody?
I think it's so that like when you have a polyp in the stomach, don't forget it. There can be something behind it. That's probably the takeaway from having a polyp. You can diagnose fundus gland polyp, but hey, if there you've got a lot of inflammation, you check for H. pylori, and or think about autoimmune gastritis, and especially if you've got samples from both the antrum and the fundus. Um, but I wouldn't necessarily say with every polyp, oh, I think about autoimmune gastritis or even H. pylori.
Yeah, this is one of those settings where several things can cause polyps. You mean Menetrier's disease or hypergastrinemia settings. Those can all lead to polyps, and that's hypergastrinemia obviously is an associated finding with atrophic gastritis as well. So if you're thinking pathophysiologically what's causing this hyperplasia or this change in the stomach, then you'll go down a list of things that can give you that hyperplastic stimulus, and autoimmune gastritis is one of those things. Um, but that's part of the pathologist's role, is to not just say, well, this is the obvious answer, but to think and to understand enough about the pathophysiology or the causes of those changes to think a little bit deeper and say, is there something more here that maybe needs to be sorted out? So these have been really good questions. Is there anybody else who has some comments or questions?
Yeah, I didn't mention about one thing is the intestine metaplasia. It used to classify as incomplete and complete. So, but right now it looks like we don't care that too much. I'm not sure is that true or we still do that.
I don't usually make that distinction between complete or incomplete intestinal metaplasia. I think detecting it is really the big issue. Finding those goblet cells and highlighting their presence is probably the key skill, and you should be practicing that so that even at low magnification, those kind of little interruptions in the epithelial layer that represent the goblet cells jump out at you as being abnormal and something you should look around for. Um,
Yeah, I don't report it. The only place that I know that does is Stanford. Um, and they said that complete type has a slightly higher risk, and so their clinicians wanted to know. But I would say that's the only place I've ever seen make that differentiation. So I think you're right, Dr. Hassel. I think in general, the point is pick up the intestinal metaplasia and definitely don't miss the dysplasia.
Yeah.
Okay, thank you.
So this has been a great session. We're going to meet again in 2 weeks, and Meng Kong has volunteered to do the case presentation for that time. We still have openings if individuals would like to volunteer to do the case presentations a month from now and 6 weeks from now. But we'll look forward to that discussion next time with Meng Kong. And thank everyone for joining and participating very cheerfully today. And no other questions, we'll just wrap it up there. And thank you very much, Yun Xiao, for your excellent presentation.
Thank you so much for having me. So it's not perfect, but it's very interesting cases, and I think these two cases are very important for our daily practice. So we definitely need to know this, and so after practicing, I think we should be able to distinguish these two kind of gastritis pretty easily.
Yeah, if you know these two diagnoses and the differential considerations, atrophic, excuse me, you really know a lot of what you need to know in the stomach. Chemical gastropathy you mentioned and went through that. These three things are the most common findings, and neither undercalling or overcalling is really a critical function here.
Okay. Yeah, thank you so much for your help, and thank you, Dr. Ranzano, for your guidance, and thank you for open for this opportunity.
All right. Well, we'll see everyone in a couple of weeks. Keep working on your self-study, and we'll see you then.
Okay.
Thank
Thank you
you.
so much. Have a great day.
Yeah, thank you, doctor.
Thank you, Mankang. Look forward to your presentation, and Dr. Rosano will reach out to you and help you get the cases you need.
My pleasure. Thank you.